too much, David. I didn't get the message that it had to be a short introduction, so I'll do my best. I do acknowledge traditional owners and particularly elders emerging, because they have a very, very big responsibility, and we all have a responsibility, those of us that are not Indigenous, to help them with that, I think. So Health Translation Queensland is, as you've seen from the opening slide, one of the NHMRC accredited research translation centres. There's about 14 around the country. And collectively we form a PAC called ARA, Australian Health Research Alliance. And they have varying constitutions and makeups. Health Translation Queensland has 13 members, including, importantly, as David said, for today, CSIRO eHealth. We have Queensland Health, which I think sets it apart from a number of the other research translation centres that do not have the luxury of a major government department as a member. We have 6 hospital and health services, 3 universities, a couple of institutes, and we're always open for more business. So if you would like to join, please get in touch. And our job is very simple: to try and promote the translation of research into health with the overall aim of improving health outcomes. And we are very conscious not to forget that overall aim of improving outcomes. So that involves increasing the amount of good stuff we do based on evidence and research. Importantly, reducing the amount of harm that we might cause collectively, either as practitioners or as a system. Trying to get rid of some waste, because that expense and cost can be much better turned into improving outcomes. And as part of that is reducing inefficiency. And from an HTQ perspective, it's absolutely clear that data is crucial for all of those things. And it's becoming clear that it's the glue that holds modern healthcare together. As David said, I'm a clinician as well, but and I have seen the transition from individual practitioners keeping paper-based records with very little overall advantage to the patient, unless you happen to be in that position of the same practitioner and the same patient over time, which is just not, that's last season, as my daughters would say. That just doesn't happen anymore. So that brings me to some observations on the history of data, and particularly an Australian perspective. And welcome Andrew, and particularly from an overseas perspective, and Christine and Annette and others from interstate. But in Australia, primary care were the early adopters of electronic health records, electronic systems of capturing data. And it's important, I think, to think about the drivers of that, because nobody went to a GP practice and said, if you institute this, you're going to make more money. The drivers were a recognition that it was an easier way to manage the more modern way of delivering primary care, with multiple practitioners looking after patients. Also, as more and more GPs are part of consortia, it's a way of collating some data and allowing some sort of interoperability. It was also very useful for billing, which was a bit of a financial attraction, but also for ease of undertaking investigations, and now progressively e-prescribing. So the benefits were sort of qualitative benefits. They weren't dollar benefits. And it was fueled by a couple of major competitors getting in there and improving each other's products very, very quickly. And now it's almost wholesale adoption in primary care in this country. Many, many years after that, some state health systems started to get involved in thinking about digital medicine. I'm pleased to say Queensland was at the forefront and still does have some advantages, which we'll perhaps come to. But it has led to some difficulties with significant differences interstate, but also intrastate in many states, where you've got different systems, and the holy grail of an interoperable system has not been achieved in most cases. And the funding has been particularly problematic. It's been patchy, it's been politically driven, especially for some of the bolt-ons, which might be for pharmacy or it might be for research, which is, of course, great interest to people in this room. So it's led to really quite different systems and different opportunities for both patients and those that work in the system. The cost has been a barrier. There's almost zero adoption in the private health acute care setting in this country. So that's creating a new divide of private versus perhaps not the right word, but private as compared to public. And that remains a problem. And the historical drivers were all about interoperability. And I can remember being at Queensland health discussions where we were playing off Cerner and Epic, and there was this big debate, and we both, Cerner and Epic, looked us in the eye and guaranteed that their systems were completely interoperable with anything that we might possibly dream up. And of course, that was their marketing people, so I won't say any more. And it's transpired that that hasn't been the case. So then if you look on that historical background at more secular recent trends, I think there's just been a very interesting move away from interoperability of systems to the wonderful realization that if you standardize the data format, then everybody's forced to comply. So it's a completely different way to look at the same problem. And that I don't think was driven by health. I think that was driven by broader digital data systems. And so it's like saying to the whole world, the only currency we're going to work in is Bitcoin or the US dollar. And if you don't want to work with Bitcoin or the US dollar, well, you're not going to be able to do business. So it's been a really important transition in thinking. And I'm pleased to say that Australia is well down the track of thinking about these things. The other thing, and who would have thought data geeks would drive patient-centered medicine, but we're now talking about the fact that the patient might actually control their own health data, which as an old practitioner brought up in the olden days, the idea of allowing the patient anywhere near their data was just extraordinary. And now we're telling the patient that they should have the data and that they should decide how that data is shared, with whom, what proportion of that data. I think that's going to be the most exciting thing that's going to transform medicine in the next couple of decades. And again, the Australian government and state governments are doing a lot of thinking about this. There's really exciting legislative reform in play. The US has done some exciting things that many here will know more about than I. So that's been some terrific changes, which I think are very exciting. The costs are a problem. The costs of digital health are significant. On the one hand, some of them are decreasing. So data movement is a lot cheaper than it was a short time ago, but the infrastructure is still expensive. And that remains a barrier, a significant barrier to, again, private health, hospital-based care in this country. And I think part of the problem is that we are not going back to the GP idea, where you don't introduce digital health because it saves you money. You introduce digital health because it provides much better health outcomes for the same money. That's a very different argument, and one that we as medics and as clinicians haven't been as I think sophisticated about as we might have been. Also, data can help, or digital can help overcome, or at least provide very efficient workarounds for a number of problems. In this country, we have the state-fed funding distribution chain, or divide, for want of a better word, and that is problematic. But if we've got a shared data source and the patient can carry their data, then a lot of that is actually overcome. Similarly, we've got an acute care system that is data reliant increasingly, but we have slightly different systems. And, we had I've just been in Melbourne, we had a crazy situation where the potential would be that you could walk up Flemington Road and in 500 metres have 4 different hospital services with 4 different IT platforms. Fortunately, common sense prevailed, but it has not always prevailed, and we still have those problems. It also has the wonderful possibility of completely, or at least largely, overcoming geographical divide. Postcode practice equity is now achievable in a country with a small population distributed over a very large area. And I don't think I could have stood up and said that confidently even a few years ago. So that is, again, a terrific advance. But there's also new barriers that data is or digital has introduced. Costs, as we know. Network availability and bandwidth is still a problem. You do not have to go far from this office or this building to find people that, both individuals that do not have access to sufficient bandwidth to contribute or to be part of a health delivery, and at a practitioner level or even a hospital level, there are places in Queensland where you can't get images reliably transferred. You can't get information reliably transferred. Now, that's rapidly getting better. It's getting better out of our hands, and there are other drivers which fortunately we can hitch a bit of a ride on. I think the other opportunity and the trend is we are inventing a new clinical specialty here. A bottle of champagne for the person that can come up with a sexy name for it. A geeky data person that's interested in health is probably not a catchy. A geeky clinical person that's interested in data is equally not particularly catchy. But, the data clinician, I don't know what we should call, but there is a profession out there that which will transform health. It will be at the leading edge of health. We are not educating that workforce properly yet. Education and providers are well behind the 8 ball in creating undergraduate programs, upskilling programs, so that we've got the army of people that we need. Not necessarily card-carrying clinicians by any means. We need support people. We need administrators. We need everybody to be skilled in this. So HTQ, how might we be able to help, or what are we interested in? Well, we're interested in convening and matchmaking, and this is a good example of that. We're interested in playing nationally and internationally, and making sure that we don't reinvent wheels or spend good money after bad. And again, Andrew is a great example of that collaboration, which is very strong. What I will say about this new clinical health discipline is that it doesn't have the same burden of egos that many of our established subspecialties have, particularly in medicine, less so in nursing and allied health. But there is a generosity of spirit and a collaborative intent, which means that it's moving much more rapidly than it might. HTQ is, and I think has an important role in driving some education upskilling type programs, and across the country, the research translation centres are very interested in workforce development. And again, I think if we could help craft a new specialty or work with people to recognise that this is something that, year 8, 9, 10, 11, 12 kids should be aspiring, and realise that this is a place where really, really exciting things happen that will have a clinical impact. So thank you very much for coming. Thanks, Jane.